Okay, thanks to all three of our presenters, and we have very little time here, but I just want to, I have questions, but I'd like to defer to those of you in the audience first to see if you have any questions or comments or thoughts to engage the panelists with before anyone?
Trauma assessment tool. In 2012, before WHO actually had the current focus on emergency care, the question was, how do we compare the performance of a trauma care system? You know, there are tools out of American College of Surgeons, but they're not really applicable to many other parts of the world. So we had a focus, sort of expert group convene and develop this, and then we pilot tested it in a few countries. We, and the process of publication is a WHO publication, but the bureaucracy takes a little bit of time. So hopefully, but if you want, I can share it with you and see if you can see it.
Here's another question in the back.
My name is Pranav. I'm from Nepal and PGY2 Emergency Medicine in Virginia, interested in global health. My question was for Dr. Jon Mark. I wanted to know a little bit more about sequential trauma education program that you explained, and also who are the eligible people, and like of all these 200 people that you trained, were they all physicians and or were they other health workers? And my second question was whether or not are you still, like, is the program still in contact with these people who have been trained? Because like different people have different intentions, different aims, and then they go career goals, they go everywhere, and then often we have found back home in Nepal, like these trainings fall through the cracks because everybody moves away. So how are you tackling that issues?
So 2 questions. The first is a little bit more about our STEPS program, sequential trauma education programs, and then also in terms of the kind of alumni network that we've developed. So STEPS was created with the idea of developing, we had looked at a number of different trauma training courses when we first started, which was now 12 years ago, and realized that trying to implement some of them in Egypt and the region would be very challenging. So we created this course, which is a 4-day, 3.5-day course in which we give the basic clinical information. Then we actually have an animal lab at the end of it, though our most recent time we've been discussing whether or not we want to go to full simulations. But at the time, the animal lab was the best option. And so we, it's adaptable, flexible. So for example, we want to now start including ultrasound because that's a critical component of trauma care. And so we can do that. We implemented it in Egypt and now in Sudan. We've done it 4 or 5 times now in Sudan. And again, really engaging the individuals. The relationship there is because most of the people we train we know or are aware of or they've come through, those folks we have relatively good connections with. In terms of our long-term training, we've got excellent connections with them. And again, this is all part of the developing the research network, but also the clinical and connection network. So we can implement it in other countries. We do a train-the-trainer model. So at this point, we've got enough Sudanese trainers that we're planning to start decrease the number of Egyptian trainers. But at this point, it's pretty much in those countries. We can implement it in other countries, but we have to find the right partnership. So we have to find someone who's willing to essentially host us, and have the appropriate, up until now, animal assimilation lab, and are willing to really partner to make sure, because the one thing we don't want to have happen is to have it diminish in terms of the quality of the course. And we're talking with AFEM North at this point about getting it kind of as acknowledged as the AFEM North STEPS trauma course. Again, those are part of discussions. But within Egypt, STEPS or its equivalent are now required by the Egyptian Board of Emergency Medicine, by a number of universities, etc.
First, I have a shameless plug, and then second, I have another question. The shameless plug is that for those of you who don't know, we'll be continuing this discussion about Fogarty, NIH, and global health in emergency medicine at the GEMA portion today at 1:30. So if you like this, there'll be hours of discussion, which actually should be quite a bit of fun. So we kind of snuck in a pre-conference during the meeting craftily here. So thank you guys very much. My question, Jean-Marc, your course steps, only physicians, or what cadres of providers can take steps, or is it aimed at?
Well, it's aimed primarily at physicians. We can adapt it for like pre-hospital providers if necessary. General, the first couple days are basic and we advance, but it's primarily been for providers.
Or like your nursing colleagues? Or no?
And again, that's something that we can develop as well. But a lot of what we talk about, it's a challenging in that you want to impart as much knowledge as possible, but also have to recognize the limitations of the setting. So the answer is we can adapt it for other, and that's the nice thing about it. But to make sure that it's appropriate for the level of the people that we're giving it to. But it's been primarily for physicians and providers.
So we are over time, but I'm wondering if anyone else has any questions, thoughts, comments. I'm going to wrap it up with one question that actually Uzma brought it up as a challenge, which is the lack of opportunities, job opportunities for those that are trained in this area. I'm wondering from any of you, to what extent do you collaborate with other departments, the Department of Cardiology or others, in terms of research opportunities and such? Is that one avenue to address the challenge that you're talking about, or is it very siloed?
No, I think it's not at all siloed, and the key to success is to collaborate. So one of our trainee is in Department of Medicine, and she's working in themes like cardiac arrest. So I think whenever we saw any opportunity which is like linked to her interest, for example, traumatic cardiac arrest, we contacted her and told her to be part of the research project. So similarly, there are a lot of other examples in other departments. We do collaborate, and research is about collaborations. So.
Yeah, and I would agree with that. I mean, the majority of our trainees are non-emergency physicians because the cadre of emergency physicians are relatively small. In fact, the number of emergency training programs are 4, 5, or 6 within the country, and not even at the university that I'm at. So we're looking to build it. We've had AFM come and have the African Federation of Emergency Medicine come and have their annual conference in Cairo. So we really have grown understanding and perspective on emergency care and emergency medicine, but it remains a challenge both in terms of from a academic perspective, as a higher education perspective, as well as from a health systems perspective. And that's part of what we're doing.
Thanks. The final thing, I think what happened in our program was, because emergency medicine was the focus, a lot of doctors and nurses who finished their training wanted a job in emergency medicine as a researcher. And as a chair of the department, obviously, it's difficult. But as far as getting a job as a researcher is concerned, it was not difficult at all. It was ability to continue and give them and position them within our own little network. That was a bigger challenge, I think.
Please join me in thanking all of our panelists.